Well, everybody, welcome to this month's LARS. It's about the safe, effective staffing guide. Laura Quinn and Lenny Yanguar are going to speak. So, a quick introduction for both of them. Lenny Yanguar is the System Senior Director of Hospital Operations at Luminous Health, where he oversees clinical and support departments, including respiratory care services. He's a respiratory therapist with more than 20 years clinical and leadership experience. Lenny holds a doctorate of business administration degree from California Southern University, a master of science in management from Wilmington University, a bachelor of science in organizational management from Wilmington University, and associate applied science in respiratory therapy from the University of the District of Columbia. He enjoys boating, fishing, and traveling. Presented along with Lenny is Laura Quinn. She is a proud respiratory therapist and currently the Director of Performance Improvement, Infection Control, and Hospital Education at a critical access hospital in Northeast Georgia. I'd like to welcome both of them. They're going to discuss once again the value of the safe, effective staffing guide and why all of us should probably be using it. I will defer to the two of you to let you begin.
All right. Well, thank you, everybody, and thanks for carving out some time in your day. Lenny and I are going to share kind of the classic use of the safe and effective staffing guide, and you'll hear us say SESG to shorten that up a little bit, and how this works in the scope of the science of labor management, and in a perfect world, how it can be used. We do know that not everyone is maybe, quote, allowed to use the SESG in their systems. And so we can talk about how it can still help you, and some different uses that that people have come up with, knowing that this is grounded in science and all of the work has been done. It's the only validated time management tool for respiratory care. So to get us started, though, I'm going to ask a couple questions. Who here, if you give a thumbs up on your emoji button there, who has heard of the Safe and Effective Staffing Guide already? 2, 3, bunch of them. Okay, awesome. And how many of you are using the SESG in your facilities? About 4 of you, it looks like. Awesome. And we'll definitely be picking your brain later and see some of the things that you've come across as far as barriers, but also how you're using it really effectively in your facilities. So and then the last question, for those of you that are not using the SESG, if you could put in the chat the reason why, and it may be that you've never heard of it before. We are totally fine with that. We're going to give you a brief introduction, but also if you do already have barriers, and we will share some of the barriers that we've heard also. But in the meantime, as you're entering those things in the chat, we're going to play a video that was recorded by Gary and Lenny and I after Summer Forum last year to give you a brief overview of the SESG.
This presentation on using the Safe and Effective Staffing Guide to bolster staffing challenges for RTs. So I want to welcome Lenny and Laura Quinn and myself, Gary Kaufman. We're going to walk you through a brief overview of the Safe and Effective Staffing Guide. Well, some of you may not have been respiratory therapists in the 80s, but you probably were alive to see some of these folks. I don't know about the mullet guy, but Sandra Day O'Connor was the first woman appointed to the Supreme Court, and Sally Ride in the upper right-hand corner was the first woman in space. Steve Wozniak invented the first PC, and those things in the lower left were 80s, and so were the guys in the middle. Now, it didn't hit the headlines, but what also happened in the 1980s? Well, the AERC, responding to membership feedback, saying we need a standardized system by which we can determine how many FTEs we have, how many staff we have in our department. And that was the genesis of the first edition of what was then called the Respiratory Care Uniform Reporting Manual, or URM. We are now in our 6th edition, and this is called the Safe and Effective Staffing Guide, and we're working and we'll be releasing the fall of 2025, the new edition. But If anyone just is itching to buy the current edition, you can go on that website that we all use and purchase it, but actually not wait for the new one to come out. Let's start off with a story, and we'll talk about this later. A younger manager contacted the AERC and said, my new executive said that I have 40 FTEs, but the numbers, the benchmarking, the productivity numbers say I should only have 24. So by next Thursday, I want you to present to our leadership team where those 16 are going to go, because those 16 FTEs will not be in the department in the future.
Well, that is a very good intro for us, Gary. I think to get us started, I'm going to ask a simple question. What is the Safe and Effective Staffing Guide?
So, Lenny, it's a great question. What the SESG is the science of labor management, bringing all of the data together so that we can safely take care of patients and having the right number of respiratory therapists to do so. And Gary gave us a bit of the history and the evolution of the Safe and Effective Staffing Guide. So I'm going to bring up the primer here, and the AARC has shown us a brief overview of what's going to be in the new guide, which comes out again September of 2025. So here in the primer, there's some tips to get you started once you've subscribed. And it's going to ask you to gather all of the activities and some of the data behind what you're doing every day. How many different activities are you doing, and how many of those different activities? So once you've gotten that data, a little bit lower here, we're going to be able to tell you what you're going to get out of the SESG. How many FTEs do you need to safely and efficiently perform respiratory care services?
Yeah, thanks, Laura. I see that one of the bullet points there states that there has to be an appropriate number of FTEs that are appropriate for the department size to care for the patient population. And it reminds me of CMS's, that's the Center for Medicare and Medicaid's conditions of participation that talks about having the right number of FTEs required to care for patients. Did you have an option to be able to show us that a CMS document of conditions of participation?
You're absolutely right, Lenny. The CMS does have this line about having the right numbers, but they don't exactly outline how many that is. Some states have outlined how many ventilator to RTs, a ratio that they find to be appropriate, but it doesn't account for all of the other activities that an RT does during the day.
Thanks. That makes a lot of sense. Can you give me an example of how somebody can be able to figure this out?
Absolutely. And that's the beauty of the SESG. So we're going to first come here to the activity names and definitions. And you'll see here there's about 250 different activities that we've outlined and have definitions behind what those things are. And so we'll pick the first one here, patient assessments. And you'll see that this is broken down into adult, pediatric, and neonatal. And the median number, the amount of time that this would require, is about 20 minutes. And we're not talking about an assessment from the doorway. We're talking about digging into the patient's medical record, any consultations, monitoring, a physical assessment. And so when we're doing that, there's a definition that surrounds all of these different activities. And so from there, we would figure out how many of these different activities are we going to be doing in a day. And we would take that over here to the tools section, to the productivity workbooks. And you'll see here the acute respiratory care patient activities is the one that we were in. And we receive a corresponding Excel spreadsheet. And from here, these are all programmed. So let's say we have 4 adult patient assessments and 2 pediatric and 0 neonatal. So we have workload hours that we can get a total amount and know how much work we anticipate having for the respiratory therapists during their shift.
Thanks. That makes a whole lot of sense there, Laura. Thank you. But I wonder, how do we account for things that respiratory therapists do that do not usually result in what we'd call productivity, like stocking of supplies and even taking lunch breaks. Imagine somebody cannot work 12 hours straight.
It's a great point. And so what these productivity workbooks and all the activities do is take the actual clinical activities and outline those. And so we have time standards for every single one of those. But what you're talking about, Lenny, is something we call support activities. And you're right, all of those things also need to be taken into account. We have patient care activities, clinical activities, and then non-allocated time. So some of those things are things that you have to do every day, which are fixed support activities, and others that are variable that may depend on different activities that you're doing, such as calibrations and things like that. And so we would take all of this, and that's really where the art comes in. So we have all of the science of the clinical activities, and then customizing this to the department that you're working in.
That's great. So that shows that we are able to have all the different variables. But what happens when you have unplanned increased workload? The RTs get slammed, and they have then to figure out how to do that work. Is that accounted for as well?
That's a great question, Lenny. We've all been there when we've had too much workload and not enough therapists to safely take care of patients. And so one project that was done at Nemours is also shared in the Safe and Effective Staffing Guide. There's several case studies that we've shared where people use this tool in creative ways and continue to capitalize on the effective staffing. And what they've done here is when they have those extreme cases, looking at the science and the numbers behind how many activities they have to do, they're able to prioritize care. And though we never want to have to do that, at least they have a system that's validated and able to take care of patients safely by prioritizing care using the safe and effective staffing guide.
Thank you again, Laura. So Gary, I'm gonna ask you, earlier in the beginning of the presentations, you focused on saving and expanding RT jobs. What if you do not have an executive breathing down your neck, or even having consultants in your organization trying to figure out your staffing? How do you do that?
Great question, Lenny. And the short answer, there's many reasons. What the Safe and Effective Staffing Guide does, it allows you to plan your department. Let's give some examples. Many departments, the patient demand, the number of services and hours required goes higher in the winter, the cold and flu season, as we call it, and then it drops off in the summer. So let's say you put your budget in for 100 FTEs and it starts July 1st. That's the start of your fiscal year. You get your July variance report and it says you are wildly overstaffed given this activity. Well, we know using the SESG that we can adjust that staff by month or quarter or season. Another way is, let's say your department has 50 ED bays or beds, and you're going to increase to 75. Do you merely take 50% of what you have and extrapolate that? Well, the answer is no. If there's the same types of patients, we'll be able to project what that is given the current status and the procedures and procedure times. So it allows you to look retrospectively. What was our productivity for the last month? But also prospectively with changes in service and demand. Okay, Lenny and Laura and I have given you a lot of information, and there's just the tip of the iceberg that we're providing today. There'll be many more resources coming in the future, but just kind of take a minute and look at what folks who have successfully adopted the SESG into their operations. Here's what they tell us. The first is start with the why. Why do we need a system, the AERC Safe and Effective Staffing Guide, when we already have a system? We count census or discharges or procedure counts or APCs. Why do we need the new one, SESG, when we have one? Well, the answer is everything we've talked about here and more resources. This is the science of labor management. It's the only nationally validated productivity metric system. The second one, and I put this in a tie with the first, honestly, it's critically important that the medical director is educated and engaged. For you to go to finance or to the chief operating officer and say, I want this new system and why, you might succeed. But if you had your medical director with you and she said something like, this is critical to our providing safe care, I support this and I will be there to see that it gets adopted and monitored. The third is identify key stakeholders. I mentioned chief medical officer, maybe your COO, certainly chief nursing officer, but who are some other ones? Finance, PI, QA, compliance. And going back to what Laura and Lenny said about the CMS conditions of participation, CMS mandates adequate number of staff. The SESG gives you a validated system to answer that question. And when you're surveyed by your Department of Health or Joint Commission or whoever surveys your hospital, you can say we are following national standards. The fourth is be concise and be focused. Start with a why, what it contains. The how is the work that you're going to do behind the scenes. So you don't need that part of your pitch to key stakeholders. The last is really the how. How are you going to implement it? How are you going to monitor it? How are you going to report to your executive team and medical leadership?
Gary, so tell us what happened to those 16 positions that we talked about at the beginning.
Well, and we talked about that. The end of the story is a good one. This manager called the AERC and AERC put them in contact with our team. We helped her using SESG validated procedure times, calculate how many FTEs she needed for her department. And guess what the number was? 40. So those 16 FTEs, those 16 employed therapists who weren't going to have a job are still on the job, thanks to the AERC and the SESG. But when you think about this, yes, this is about respiratory therapists, helping us have the right numbers of staff to provide great care. But who's really the why? This is our why. This is why we're RTs, why we use the science of labor management, and why we're proud to do so. Thank you.
Okay. It appeared the video was off a little bit, but if you've been in the Safe and Effective Staffing Guide, there are the activity names and definitions, and then there are all these workbooks. And so you're not having to do any of the work yourself. You're plugging in by number how many of the different activities you do, and that's what will give you your final staffing numbers as far as the clinical activities. And then in the segment that Lenny was talking about, the support activities is really where maybe not the creativity, but the creativity comes in as far as figuring out what other things that your RTs are doing, whether it's clinically related, such as calibrations, or even if it's just continuing education and lunch breaks, things like that. So in a perfect world, everyone would use this. We'd all have the right number of RTs to care for patients, but we know that it's not always like that. And as you see in the chat there, not everybody is even allowed to use the SESG. And even though you might not be able to use it entirely as it's designed, Lenny, I think you had an example of where your facility used this for a very creative reason. So let's open up with that story to get people's brains going in that direction.
So the creativity, if we can call it that, is based off of an annual survey that is conducted in many organizations. So the employee engagement and the culture of safety survey was driving us organizationally, not just the respiratory therapy department, but across different departments, that the areas of opportunity included workload and work pace. So our staff feel that we are killing them with the amount of work that we are asking them to do. And we actually, in respiratory therapy, had some turnover, and we could kind of drive some of the reason of the turnovers we were having towards the workload and work pace. And so when the AARC was going to release a safe and effective staffing guide last fall, we spoke with our executives, and they were eager also to understand how our current staffing metrics would measure against the AARC Safe and Effective Staffing Guide. So that was that way of looking at it from the perspective of how can we measure ourselves against what is validated. And that was just the idea, and it didn't end up working as well as we did, because as it didn't work as well as we wanted to, because we are still in that phase of trying to implement the process. We hired a leader. The leader didn't stay long, but during their tenure here, they're the one that purchased the AARC Safe and Effective Staffing Guide. One of the things we learned is if the leader leaves, and so does the Safe and Effective Staffing Guide, because it's purchased under a person, the actual leader for the department. So that is some of the challenges that we faced here at our organization, but at the same time, kind of trying to think outside the box of how can we be able to utilize the Safe and Effective Staffing Guide if we were not going to use it in the traditional way that it was initially intended to be used. Laura?
Right. And we have several leaders and people that are really well versed in the SESG that are on our kind of expert panel of SESG that also haven't adopted it from a corporate standpoint, but they're able to use it to distribute workloads, and use it kind of more behind the scenes, and also using it as a comparison so that if they are pushed maybe too far one direction, in decreasing staffing, they're able to stick up and say, here's the numbers. We know you're not using this in the financial side and the productivity side in maybe the EMR or anything like that, but it allows therapists and leaders to say this is what's truly right, and gives them more fuel to their fire.
Yeah, Laura, I can add that similar to the case that Gary presented in the video, where there was a question to cut 16 FTEs from that department. I look at the way our department was structured. We were more the opposite, because the feeling is that we are not properly staffed, and we really wanted to use, and we haven't done it, I think we're still going to do it. We want to use this validated tool to present to our executives to say, I think we are not effectively staffed, and would hope to have additional staff added to our department in order to have proper staffing based off of what the SE. By the way, I will say this. When Laura and Gary and myself were working on this, I could never be able to say the SESG. I had to actually say Safe and Effective Staffing Guide. It's one of those. I cannot be able to abbreviate it while it's easier for Laura and Gary. Just to mention that. Back to you,
It's
Laura.
totally true, and just like people can use the SESG in the really traditional way and adopt it completely, integrate it into their EMR. We have case studies, how it's been brought into Epic, and so even though you can do that, there's other aspects that can be used. So, and I was actually KOZDRONS. You said that you have corporate guidelines, and I wonder if you'd share with us a little bit about that, what the corporate guidance is. Sorry to put you on the spot, but
yeah, that's okay. It's Stephanie. My name's Stephanie. So our forms are loosely based on the SESG. They're not they don't specifically reference it, but it's very obvious they're loosely based on the SESG. So we do have like sort of a tally system. Each tally is roughly 15 minutes, and we do have a large variety of things to choose from. So there are fixed and variable choices. We also have other as a choice where we can just fill in where our time is going, which is very helpful. I mean, it accounts for a lot of things that just pop up. I mean, even if it's just like family in the hallway that ties you up, you can account for that time that way. So I feel like it's a pretty good system. Every so often we do have challenges with census dropping and nursing wanting to revert to that EPOB, but it usually works out for us okay.
And I was just going to ask you actually, do you use it kind of as a daily tool, or do you use it prospectively, like into your busy season, or is it more for the for that day's workload, or larger than
We
that?
have the forms built into our documentation. So for most of our daily tasks, like treatments or a BiPAP setup, oxygen, even just anything that we're already documenting on, there's an extra tab that's a charge sheet. So we fill out that charge sheet basically with every encounter. And then the following day, we can run the report for the day prior. I mean, you could kind of estimate it if you wanted to use it going forward, but every night it runs at the corporate level, and then we can run the report and see what our numbers are for the day prior, and it breaks it down for us in an Excel sheet so we can look at it by therapist, by patient, or just total numbers, which is pretty nice. Or by modality, we can break it down that way also to see where exactly our time is going or which charges we're missing.
Gotcha.
It works out pretty well though.
And so, do you have much seasonality where you are? To your like, do you get busier in the winter? And
Yeah,
use
I mean,
that to flex,
I'm in
or
Sewickley, so I'm right outside of Pittsburgh. Yeah, I mean, we do have some seasonal weather here, but yeah, our system we have 175 hospitals across the country, so everybody's using the same system. It's standardized. So I guess there would be some fluctuations in the warmer weather states where things are a little more balanced than they are here.
gotcha.
And
So
I have used those sheets and run those reports to justify, like if our census drops and we're very busy, because they don't always correlate. I have used those forms to say like, no, you can't flex us. Here are our numbers, and have been able to have them back off. So, yeah, and I've used that to get additional staff as well. So, yeah, it's not pretty well.
and that's the perfect example, right? Even though SESG might not be fully integrated into your system, you're still using it, and yes, RTs understand much better than some of our other clinical
Yeah.
counterparts that just because the census is lower doesn't mean that the RT work has changed at all, maybe even gone up. So that's awesome. Thank you for sharing that.
You're welcome.
Some of the other barriers, I think I briefly mentioned about being integrated into EMR. I think that's one of the challenges that people face is speaking with the finance groups and having them understand, wrap their head around SESG and how we can tally our work in that way. And just want to put it out there that we have info@sesg.org that if you are a current user, we have a team of people that are happy to answer questions and sometimes just brainstorm with people in terms of how they can get the most out of the tool.
Yeah, Laura, and as you talk about the flexing of staffing, I don't know, I mean, how many of the participants here today have Apex from the AARC, but one of the standards of Apex that Gary informed us that he was one who drafted that standard asks that the department has to have defined staffing plan that is used to project anticipated staffing and is used consistently to schedule and flex the staff. So the Safe and Effective Staffing Guide can also be used to demonstrate to the AARC that you do have a staffing plan that is consistent to the standards of the APEX recognition.
Right. And I'm not sure if with the Apex recognition, I'm not sure if everyone on the call knows that, but it's really the standard of the most kind of the gold standard of respiratory care departments, looking at AARC membership, having medical director engagement, and one of those components, as Lenny said, is the productivity and staffing metrics. I guess we'd like to open it up to any questions, and I can also bring back I can bring up the Safe and Effective Staffing Guide and walk people through if there's any questions on kind of the nuts and bolts of it. But what questions does anyone have? Or comments?
Thanks, Laura. This is good. Yeah, and I hope we get some questions at least. You know, Stephanie has the ability to sort of utilize it under their corporate guidelines. Here at I work for Allegheny Health Network. When I came on board as a leader in this department, this was one of the things I was fighting for like crazy. It took me several years, but finally being able to sit in front of basically the highest executive when it comes to finance and we are not a single hospital is doing the same thing, yet we're all doing the same thing. So I was able to, it took me like a million different ways. Now that it has all the workbooks and everything, it would have been really great because they really would have understood that, because all they did was open workbook after workbook after workbook to show me, well, see, this is this and this is that. And we finally got it on board when I was able to show that every single hospital was doing the same thing, but you were given this person this many minutes for this thing, or not enough time here, or you were just basically making something up. And everything was either a 1 or a 0 in their mind. And when they finally understood exactly how respiratory therapy works, it made a big difference. And we're comparing apples to apples now across the network instead of apples to oranges.
Can you point to anything in your conversations? And it's not unusual. We hear this a lot, actually, where people feel like they're banging their head against the wall in speaking to people that don't necessarily speak our language on a daily basis. Is there anything you can point to that seems to click with them and really make a difference?
You know, I don't know what it took that made her flip the switch and understand, yeah, we can institute this. I really don't remember. Because it's been, I think we managed to do it about 4 or 5 years ago. We did get an additional the C-suite leader come on board as kind of like our sponsor for respiratory therapy across the network, because we don't have a network director. There's just a bunch of us in individual silos that work together once a month to make sure that everybody has what they need. You know, we address staffing, we address epic issues, we address everything. But that person came on board and he kind of helped, I guess, put it more in their language than I was able to put it in their language. So that was probably the thing because she actually came in the room with us, because I had done it previously just solo myself for this hospital. And then we got her in front of all of us. We were all speaking that, you know, we want to know that we're all being treated the same across the network when it comes to time standards or whatever. So that, you know, one hospital needs 100 therapists, but they're only given 30. And one hospital needs 30, but they've got 100. So we wanted to make that all, you know, the right way. And he was kind of able to talk her through a couple of things. And we didn't get everything we wanted, but we got the most important things. At least 85% of what we wanted, we got. You know, but their saying was, well, this is not going to be your argument for more staffing. Okay. It led to an argument for more staffing, but immediately we said, nope, Nope, that's not what we're using it for. We're using it so we can all be on the same page.
I think that definitely speaks their language a lot, just having the consistency across groups. And Gary does a ton of consulting with different organizations using the SESG. And Gary, jump in, but 9.9 times out of 10, it leads to increased staffing. And I think it shows the value of what we do at the bedside when for those leaders in finance or things that don't speak to us generally.
Yeah, I
Gary,
think
is
it's a
that
good
true?
point. Yeah, it's a good point, Laura. And I think we always have stated since the URM 40 plus years ago, this is not a tool to fluff the numbers, that we use it to get more staff. Some people have found that they actually have too many staff, particularly when they look at identifying, quantifying the low value efficiency, IS mucomist, blend aerosol therapy. But two comments, and Steph's comment made me think about something. For those watching this live or on demand, you might get pushback from administration saying, we got a metric. It works. It's not perfect, but kind of good enough is okay. I would ask, how do you determine nurse staffing? Real simple example. Go in your ICU, 10 individuals. How many RNs do you have? Typically 10. Now, why is that? It's based on patient need acuity. You go down the hallway to med surg, you have 10 rooms, 10 patients, maybe 2 RNs. Well, 10 doesn't equal 2 any more than a nebulizer treatment is the same time equivalent of a ventilator. So I think for those that are struggling to make the case, and Lord knows I have more than one occasion to look at that. The second comment is the new Joint Commission standards were released in January of this year. They used to be about this much, if you look at the video, now they're about this much. They're very, very skinny compared to what they used to be. But there's a brand new chapter on nursing. I'd encourage everyone to read that and kind of, find RN and replace it with RT, because there's a lot of information there on safety and quality that's written for nurses, but could be applied to therapists. And also the CMS conditions of participation. I am sure there's nobody on this call that has ever read that other than me. But if you read it, there are a number of phrases in there that talk about adequate numbers, adequately trained. And as we know, most recently, a couple of weeks ago, there's an organization looking at replacing RTs with another provider, another clinician. And as I read it, that does not satisfy it because of scope of practice, education, and training. So those are my thoughts. Keep up the good work. I know I don't want to speak for Lenny and Laura, but I think we'd all make ourselves available to help anyone who's struggling to define and document their staffing.
In addition to that, too, as far as other resources that are in the SESG, we have templates on how you can speak to your leadership. So if you're just at the beginning stages of this, there's a lot of assistance out there. I think our SESG group wishes that we had more people coming and asking us questions because we're passionate about it. This version of the SESG was countless hours. I can't even begin to tell you the amount of hours that goes into this, and so we all really enjoy it and are happy to brainstorm with people too. Sorry, there's background noise, so I'm gonna go on mute. Lenny, did you have anything else that you wanted to add? And also, if there's any questions from people.
No additional comments. I'm just going to say that using a validated tool does help any conversation you have with your one-up or even across the organizations, as we are now having many of our organizations are regional. Ensuring that the conversation is valid, you use an evidence-based tool, such as the Safe and Effective Staffing Guide, and therefore it's just a good tool to have. It's a good tool to use in conversations and or even as we said, you can be able to sometimes lead to having more staff, but at the same time, it can also lead to even distribution of staff across health systems.
One small comment about across health systems. We've revised some of the definitions. One of the groups of definitions that we changed was the oxygen delivery systems, and heated high flow versus BiPAP versus venti mask versus oxy mask. We've made those based on time standards of the setup and the assessment, where I think typically in the past, if you were just one hospital that was using this, you already knew what device you were using. But then going across different hospitals, maybe you had one that had a different name or said that it had different characteristics. And so, how do you account for that? And does one take more time to set up or time to assess than the other? And so we've made those to be kind of a universal language. We have 4 categories of oxygen therapy, going up to heated high flow, nasal cannula, nasal insufflation, so that we're all speaking the same language, so it can be used across health systems, that even though you don't have the same products at hand, you can still categorize these. And then one other change was looking at ventilator day as a whole, instead of if people were doing ventilator assessments, whether it was Q4 or Q6, we're looking at the time spent during the entire day. So those are some changes that came with the latest Safe and Effective Staffing Guide that can be used to your benefit.
Well, thank you both. Yeah, and Lenny, to your point, they always want data. They want a ton of data. They want evidence-based data. Any of us that roll up to nursing know that. They always want evidence-based standards. This is perfect. And like you just said, Laura, categorizing things. We don't all have the same devices. Here at our network, that's one of the things that our leadership group does. Once a month, we are standardizing as much as possible, so that because our physicians rotate through all of the facilities, be it our neonatologists or our pulmonologists, or they're seeing the same stuff, so that they're not surprised when they walk in and they don't know what's going on in their mind. Some of us will say they never know what's going on, but that's a whole nother conversation for another time. I really don't. I really want to thank both of you. I mean, this is fantastic. I wish we could have had a few more people on, because this is something I think that everybody needs. I've tried to get this when it was the URM and other places I worked many, many years ago. I kind of piecemealed it together myself when I was working in other places, so that benefited me. At least I could argue my case, not the manager's case, but my case at that time. Yeah. Does anyone on the call have any other questions or comments that they'd like to submit? I see something's in the chat, but I think that might be Gary going to work in the chat. Yeah, it's Gary. Good job, Gary.
And for anyone that is going to be listening to this recorded, please feel free to reach out. We love questions and are happy to help anybody that's interested.
Well, we greatly appreciate that. Thank you so much. If no one has anything else, it looks like you're gonna get about 13 minutes back in your day. That'll work out for quite a few of us, I would imagine. Well, thanks everybody. I appreciate it. Lenny, Laura, thank you so much. Gary, really appreciate you connecting with us, them with us. And then the next LARS meeting is going to be August 3rd, or August 13th. Sorry, August 13th. And that's going to be Phil Stark. He's going to be discussing simulation on a budget. So spread the word, everybody that's on the call, so we can get a few more folks on there. We'd appreciate it. Thank you. Well, everybody.